Welcome to the deep dive. Today we're venturing into a really vital area of children's health, neurological and cognitive disorders. We've got a comprehensive chapter here that, well, it really lays the groundwork for understanding these often complex conditions.
Yeah, it's a great overview.
Think of this as your shortcut, kind of, to grasping the essentials, whether you're already familiar with this area or maybe coming to it fresh.
Right.
We'll be navigating, everything from cerebral palsy through to autism spectrum disorders, really pulling out the crucial insights.
And as we explore these, two fundamental principles will really guide our discussion. Intracranial regulation, that's the body's ability to keep things stable inside the skull, and safety.
Safety, absolutely paramount.
Definitely, especially with kids facing these challenges.
Exactly. And, right from the start, to get us thinking, the chapter throws out a really practical question. Imagine a child with a VP shunt for hydrocephalus, and you spot potential signs of increased intracranial pressure. What should you actually do?
Yeah, that hits home the real-world importance, doesn't it?
It really does. And we'll circle back to the answer later on.
Good plan. So our goal today is really to break down these neurological and cognitive issues into, understandable pieces.
Yep.
We'll look at what defines them, how we gather key info through assessment.
The data collection part.
Exactly.
Yep.
Then the vital interventions and the core concepts behind each one, taking dense info and making it, genuinely clear.
Okay, let's start unpacking this then. First up, cerebral palsy. The chapter calls it a disorder impacting movement and posture, stemming from abnormalities in the brain's motor systems. What are the basics we need to grasp?
Well, a key thing is understanding the types. The most common is spastic cerebral palsy.
Spastic, okay.
And spastic refers to muscle issues that come from the upper motor neurons. Think of those as the nerve pathways running from the brain down the spinal cord.
Got it.
Damage there often leads to that increased muscle tone, that stiffness. Less common types are athetoid, that's more about involuntary fluctuating movements.
Right.
Ataxic, which hits balance and coordination, and then mixed types, which are, a combination. Understanding this upper motor neuron link helps predict the motor challenges.
Okay, that makes sense. So when you're assessing a child, maybe looking for cerebral palsy,
Yeah.
what are the key signs? What observations really matter?
That's crucial, the data collection piece. You might see a lot of irritability, maybe crying more than usual, and definitely difficulties with feeding.
Feeding issues, okay.
Developmentally, you might see delays in hitting those motor milestones.
Like rolling over or sitting up.
Exactly. And abnormal motor performance, changes in muscle tone, often stiffness or rigidity in arms and legs. Another big one is primitive reflexes hanging around too long.
Primitive reflexes.
Yeah, like the Moro reflex, that startle response.
Yeah.
Or the tonic neck reflex, where turning the head makes the arm on that side extend. These should fade by about 3-4 months, definitely by 6 months.
So if they're still there, that's a red flag.
It can be a sign of neurological issues, yeah. You might also see weird posturing, like a pisotenos, that's a really exaggerated arching of the back. Figure 35:1 in the source shows it well.
Okay.
And importantly, seizures can also occur in children with CP.
That gives a much clearer picture of what to look for.
Mm-hmm.
So moving to support and interventions for a child with CP, what are the main goals? What do we do?
The big goals are, first, early recognition, and second, implementing strategies to help the child reach their absolute maximum potential.
Maximize abilities.
Exactly. And that really points to needing a multidisciplinary team. Physical therapists for movement, occupational therapists for daily living skills.
Speech therapists, too.
Absolutely, for communication and feeding. Plus, educators, maybe even recreational therapists. It's vital to figure out the child's developmental level and cognitive abilities. They might not match their age.
Right.
Early intervention programs, getting them involved in school, super important. We might use mobilizing devices to help with movement and prevent deformities. And communication talk at their developmental level. Use simple language, visuals if needed. Safety is huge. Remove hazards. Maybe helmets if they fall a lot. Seizure precautions if needed.
Makes sense.
Age-appropriate toys that also fit their developmental stage are key. Positioning them upright after meals helps digestion, reduces aspiration risk.
Good tip.
Medications might be used for muscle spasms, which can be painful, and also to control seizures. And finally, parent education and support groups are absolutely essential.
Okay, great overview of CP. Let's transition now to head injury. Broad term, obviously. The chapter starts by defining it as any pathological result of mechanical force to the skull, scalp, meninges, or the brain itself. What are the first distinctions we need to make?
The basic split is between open and closed head injuries. Open means a skull fracture or penetration.
Okay.
Closed injury is usually from blunt trauma. And in some ways, these are more concerning because of the higher risk of intracranial pressure, or ICP, building up inside that intact skull, the closed vault idea.
Right, nowhere for the pressure to go.
Exactly. And it's important to know the link between closed head injuries and shaken baby syndrome. How it actually shows up clinically really depends on the injury type and how high that ICP gets.
And on that critical point, increased ICP. The chapter stresses that a change in level of consciousness is often the very first sign. What are some early indicators?
Yeah, and they can be subtle at first. You might just see slight vital sign changes, maybe blood pressure creeps up a bit or heart rate dips slightly initially, and really subtle shifts in consciousness, maybe just more irritable or not quite as responsive as usual.
Okay, subtle changes. What about in infants specifically?
In babies, look for irritability, a high-pitched cry different from their usual cry, a bulging fontanelle, that soft spot,
Right.
an increase in head circumference measurement, dilated scalp veins, maybe that Macewind sign, the cracked pot sound when you gently tap the skull,
Wow.
and the setting sun sign where you see the white part of the eye, the sclera above the colored part, the iris.
Like the sun setting, okay.
Uh,
And in older kids?
Older kids might complain of a headache, nausea, vomiting, maybe vision changes like double vision diplopia, or they might even have a seizure.
Unfortunately, if that pressure keeps rising, there are late signs too, indicating a more serious situation. What are those critical late signs?
Yeah, these late signs mean more significant brain compromise. You'll see a further drop in their level of consciousness, maybe even heading towards coma, that deep unconscious state.
Okay.
Bradycardia, a really slow heart rate, that's a key late sign. Also, reduced motor and sensory responses. Pupil changes are critical. Size, shape, reaction to light. They might get dilated, constricted, unequal, or react sluggishly or not at all.
And the posturing.
Right. Figure 35-2 shows this. Decorticate posturing, flexion, arms bent in, wrists flexed, legs extended. That often points to severe cerebral cortex dysfunction.
Okay.
Even more serious is decerebrate posturing extension, where arms and legs are rigidly extended, arms rotated out. That suggests damage down at the midbrain level.
That sounds very serious.
It is. You might also see breathing pattern changes, like Cheyne-Stokes respirations, that cycle of deep, fast breathing, then periods of no breathing, apnea, and ultimately coma.
Wow. A very concerning picture.
Yeah.
So when it comes to interventions for a child with a head injury, what are the immediate priorities? What does the nurse need to do?
First thing, absolutely, if there's any suspicion of a spinal injury, stabilize the neck and spine. Immobilize.
Priority 1.
Definitely. Once spinal injury is ruled out, raising the head of the bed maybe 15 to 30 degrees, if nothing else prevents it, helps venous drainage from the brain, can lower ICP.
Okay.
Airway, of course, make sure it's clear. Give oxygen if needed. Check thoroughly for other injuries. Keep the head midline. Don't want to compress the jugular veins. That can raise ICT.
Right.
Constant monitoring. Vitals, neurofunction, especially level of consciousness.
Yeah.
Report any sign of rising ICP immediately. Minimize stimulation noise, lights. Try to keep infants calm. Crying can raise ICP.
Avoid sedatives.
Generally, yes, in the acute phase. They can mask changes in consciousness, make assessment tricky. Initiate seizure precautions. Box 35-1 details those. Monitor responsiveness to pain. A decrease is significant.
Okay.
Probably NPO, nothing by mouth, or maybe clear liquids at first, risk of vomiting. Manage Gervie fluids very carefully. Don't want to cause brain swelling or overhydrate. Monitor fluids and electrolytes closely too, especially if the hypothalamus or pituitary might be injured.
What about wounds or drainage?
Check wounds and dressings carefully. Specifically, look for drainage from the nose or ears. Could it be CSF, cerebrospinal fluid?
How do you check that?
CSF tests positive for glucose on regent strips. If it's positive, notify the RN immediately. And never do nasal suctioning if there's a suspected skull fracture risk of the catheter going into the brain.
Oh, okay.
Meds might include acetaminophen for pain, anticonvulsants, antibiotics if needed, maybe tetanus prophylaxis. Be ready for corticosteroids or osmotic diuretics if ordered for cerebral edema.
Anything else to watch for?
Monitor for signs of brainstem involvement. Box 35-2 lists those. And watch for epidural hematoma. A key sign is asymmetrical pupils, one dilated and non-reactive. That's a neurosurgical emergency. Notify the RN stat. And again, that CSF glucose test, crucial.
Okay, very thorough. Let's shift now to hydrocephalus. The chapter defines this as an imbalance CSF production versus absorption, often due to things like malformations, tumors, hemorrhage, infection, trauma. leads to head enlargement, increased ICP. What types do we need to know?
The key distinction is communicating versus non-communicating hydrocephalus.
Okay.
Communicating hydrocephalus means the problem is with absorption, usually in the subarachnoid space, that space around the brain and spinal cord where CSF circulates. The flow within the ventricular system, the fluid-filled spaces inside the brain, is okay.
So a drainage problem.
Pretty much.
Oh.
Non-communicating hydrocephalus, though, means there's a blockage within the ventricular system itself, so CSF can't flow properly through those internal pathways.
Okay, blockage versus drainage. How does hydrocephalus typically present? Does it look different in babies versus older kids?
Yeah, signs can vary with age. In infants, you often see that increased head circumference, maybe thin, separated skull bones, that miss one's crack-to-pot sound again.
Right.
The anterior fontanelle, the soft spot, might be tense, bulging, not pulsating normally. You might see those dilated scalp veins again, frontal bossing, a prominent forehead, and those setting sun eyes we mentioned with ICP.
Okay, and older children?
And might be more subtle initially. Behavior changes like irritability, lethargy, maybe morning headaches, nausea, vomiting, ataxia, that uncoordinated gait, or nystagmus, the involuntary eye movements.
In late signs.
A late, really concerning sign in both age groups is that high-pitched, shrill cry. That's a big indicator of high ICP. And seizures can occur, too.
So what are the main surgical options for managing hydrocephalus?
The goal is basically to bypass any blockage and drain the excess CSF to somewhere else in the body where it can be absorbed. The most common procedure is placing a ventriculoperitoneal shunt, a VP shunt.
VP shunt, okay.
Figure 35-3 shows this. A tube goes from one of the lateral ventricles in the brain down into the peritoneal cavity, the abdominal space. CSF drains there and gets absorbed.
Makes sense.
Another type is a ventriculoatrial or VA shunt. Drains CSF from the ventricle into the right atrium of the heart. Might be used in older kids or if there are abdominal issues.
Do shunts need changing?
Often, yes. Shunt revisions are common as the child grows. Another option for some types of non-communicating hydrocephalus is an endoscopic third ventriculostomy, or ETV.
EPV.
Yeah, they create a small opening in the floor of the third ventricle, letting CSF bypass a blockage, often in the fourth ventricle, and get absorbed normally. But it's not suitable for all types.
Got it. What about nursing care before and after hydrocephalus surgery? What's important?
Pre-op, monitor intake and output closely. Small, frequent feeds until they need to be un-PO for surgery. Frequent head repositioning, maybe a special mattress like an egg crate to prevent skin breakdown on the scalp, and lots of prep and support for the child and family.
Post-op.
Continuous monitoring vitals, neurosigns, I&O. Position them on the unoperated side, usually, to avoid pressure on the shunt valve. They might be kept flat initially, as prescribed, to prevent draining the CSF too quickly.
Yeah.
Watch constantly for signs of increased ICP. If you see them, you might elevate the head of the bed slightly, maybe 15-30 degrees, to help gravity drainage through the shunt, and you absolutely notify the RN immediately.
Right.
Measure head circumference regularly. Monitor for infection. Check the dressing site for redness, swelling, drainage. Comfort measures, prescribed meds like pain relief or antibiotics. And reinforcing parent education is huge, teaching them to recognize signs of shunt infection or malfunction.
What are the signs?
In infants. Irritability, that high shrill cry again, lethargy, poor feeding. Toddlers might show headache, poor appetite early on. Older kids. A change in their level of consciousness is often the most valuable sign.
Very important for parents to know. Okay, let's talk about meningitis now. Defined as an infectious process in the central nervous system caused by bacteria or viruses. Can be primary or secondary to other things like surgery or infections. How is bacterial meningitis usually diagnosed? And what are common causes?
Bacterial meningitis diagnosis relies on examining the cerebrospinal fluid, the CSF, from a lumbar puncture, a spinal tap.
Okay.
In bacterial cases, the CSF is typically cloudy, pressure is up, white blood cell count is high, protein is high, but glucose is low.
Low glucose, high protein, cloudy. Got it. Common bacteria.
Some common ones are Haemophilus influenza type B, Streptococcus pneumonia, and Neisseria meningitis. It's really important to note that meningococcal meningitis from Neisseria meningitis can cause epidemics and spreads via respiratory droplets from the nasopharynx, the upper throat area.
Okay. And viral meningitis.
Often caused by viruses like mumps, paramyxovirus, herpes virus, enteroviruses.
What are the typical signs and symptoms that might make you suspect meningitis?
It varies by type, age, how long they've been sick, but common things are fever, chills, headache, maybe vomiting or diarrhea.
Okay.
Infants might feed poorly, lose appetite. Neutral rigidity, stiff neck is classic, though maybe less obvious in young infants. They might have a weak cry or that high-pitched shrill cry again.
Altered consciousness.
Definitely. Lethargy, irritability, big concerns. Bulging fontanelle in infants. Older kids and teens might show a positive. Koenig's sign, can't straighten the leg when the hip is flexed, or Brudzinski's sign, flexing the neck makes the hips and knees flex involuntarily.
Any other signs?
Muscle or joint pain, especially with meningococcal or Haemophilus types. Petechial purpuric rashes, those small red-purple spots that don't blanch, often seen with meningococcal. And maybe a chronically draining ear could point to pneumococcal meningitis.
What are the key nursing interventions for a child with meningitis?
Top priority. Respiratory isolation, at least for the first 24 hours after starting antibiotics. Administer those antibiotics ASAP after the LP is done. Give antipyretics for fever. Anti-seizure meds might also be needed. Assist with neurochecks, monitor closely for seizures, and also for SIADH syndrome of inappropriate antidiuretic hormone secretion.
SIADH.
Yeah, it causes fluid retention, low sodium levels, monitor level of consciousness, irritability, watch for that purpuric petechial rash and signs of blood clots, thromboemboli. Monitor nutrition, INO, check for hearing loss, which can be a complication.
Anything else?
Identify close contacts, they might need prophylactic treatment. And remember, the pneumococcal conjugate vaccine recommended starting at 2 months helps prevent pneumococcal meningitis.
Good point on prevention. Okay, let's shift to submersion injury. Defined as survival for more than 24 hours after being submerged in fluid. What are the main dangers here?
The biggest dangers are hypoxia, lack of oxygen, and asphyxiation, suffocation. These lead to widespread cell damage. Brain cells are super vulnerable. Irreversible damage can happen after just 4 to 6 minutes without oxygen.
Wow, that fast.
Yeah. Other big concerns are aspiration, inhaling fluid into the lungs, and hypothermia, that dangerous drop in body temp, especially in cold water.
What determines the outcome?
It largely depends on how long they were submerged in non-icy water and how they responded initially. Better prognosis if it was less than 5 minutes and they had neurological response, reactive pupils, normal heart rhythm.
And poor prognosis.
If submersion was over 10 minutes and there was no response to CTR within 25 minutes, the outlook is often poor, severe neurological problems, or death.
What are the key nursing interventions for a submersion injury?
Immediate focus is on ventilatory and circulatory support. Intubation, mechanical ventilation might be needed if there's significant brain injury. Monitor respiratory status constantly. Problems like cerebral edema can show up even 24 hours later.
Okay.
Watch closely for aspiration pneumonia lung infection from inhaling water. Frequent neurochecks are critical. If there's no spontaneous, purposeful movement or normal brainstem function after 24 hours, it suggests severe deficit.
And prevention.
Absolutely vital. Reinforce parent teaching on water safety. Constant supervision around any water source. Cannot stress that enough.
Definitely. Now let's turn to Reye's syndrome. Described as acute encephalopathy, usually following a viral illness. What are its key features and causes?
Reye syndrome involves acute brain dysfunction encephalopathy with cerebral edema, brain swelling, and fatty changes in the liver. Definitive diagnosis comes from a liver biopsy.
Cause.
The exact cause isn't totally clear, but it often follows viral illnesses like the flu or chickenpox. Critically, there's a strong link between Reye syndrome and giving aspirin or other salicylates to kids with fever or these viral infections.
So no aspirin for kids with flu or chickenpox?
Right. That's why it's contraindicated. Acetaminophen or ibuprofen are the usual go-tos. Early diagnosis and aggressive supportive care are crucial. Main goals are maintaining brain blood flow and controlling that ICP.
What assessment findings might point towards Reye's syndrome?
Often there's a history of a viral illness about 4 to 7 days before symptoms start. Initial signs might be malaise, just feeling generally unwell, plus nausea and vomiting. Then you might see signs of liver problems, like increasing lethargy. Progressive neurological decline is a hallmark. Blood tests often show high ammonia levels, another sign of liver dysfunction.
What are the nursing interventions for Reye syndrome?
Provide a quiet, calm environment, minimize stimulation, monitor neurostatus constantly LOC, signs of increased ICP, watch for signs of liver dysfunction, monitor liver function tests, keep track of INO, and monitor for bleeding or problems with blood clotting, like prolonged bleeding time.
Okay, quiet environment, close monitoring. Let's switch gears to seizure disorders, defined as excessive, unorganized electrical brain discharges. How are seizures classified?
Broadly, based on where they start in the brain and how they look. Generalized seizures involve both sides of the brain, usually with loss of consciousness.
Types of generalized.
Tonic-clonic, the classic stiffening, then jerking. Absent seizures, brief staring spells. Myoclonic, sudden, brief muscle jerks. Atonic seizures, sudden loss of muscle tone, causing falls, sometimes called drop attacks.
Okay. And partial seizures.
These start in one specific brain area. Simple partial seizures have motor, sensory, or autonomic symptoms, but no loss of consciousness. Complex partial seizures do involve altered consciousness, maybe with automatisms like lip smacking.
Got it. Any others?
There's also an unclassified category if there isn't enough info. Chapter 55 goes into more detail on seizures generally.
What information is important to gather when a child has a seizure? What should a nurse observe?
Get a detailed history from parents. When did it start? Any triggers? What did the child do before, during, after? Past seizure history is key to frequency, duration, type. Ask about an aura, any warning sensation beforehand.
And during the seizure?
Monitor closely for apnea, start breathing, and cyanosis, that bluish skin color indicating low oxygen.
After the seizure?
Expect a postictal state. They'll likely be disoriented, confused, and often very sleepy.
The chapter mentions Box 35-ton on seizure precautions and Box 35-3 on emergency treatment. Can you highlight the key points?
Sure. Seizure precautions, Box 35-1, are all about safety. Padded side rails up when resting, waterproof mattress pad, medical ID bracelet or info. Safety instructions for activities like swimming always with a buddy and protective gear like helmets for biking. Make sure all caregivers know the plan.
Okay, safety first and emergency treatment, Box 35-3.
Priority is airway. Have suction and oxygen ready, time the seizure accurately. If they're standing or sitting, gently lower them to the floor on their side to prevent aspiration, pillow under the head, loosen tight clothing, remove glasses, clear the area of hazard.
Don't restrain them.
No, let the seizure happen. Don't try to restrain. If they vomit, turn them on their side immediately. And critically, never put anything in their mouth. Major risk of injury or airway blockage.
Good reminder.
No food or drink until fully awake. Give rescue meds if prescribed. Stay with them until fully conscious. Note any incontinence. Document everything. Onset, duration, movements, postictal state.
Great summary. Okay, moving on to neural tube defects. CNS defects from the neural tube not closing properly during embryonic development. What about folic acid?
Yes, the recommendation is strong. Adequate folic acid intake for women of childbearing age, especially around conception and during pregnancy, significantly reduces the risk. These defects can also link to other issues like sensorimotor problems, dislocated hips, clubfoot, and hydrocephalus. Surgery to close the defect happens soon after birth.
What are the different types outlined?
Two main groups, spina bifida occulta and spina bifida cystica. Occulta is milder vertebrae, don't close fully, usually low back, but spinal cord is intact, not visible, no meninges exposed, usually no neurodeficits.
Okay, and cystica?
That involves protrusion of the spinal cord meninges or both through the defect. Visible sac-like bulge, usually lumbar or sacral. Subtypes include meningocele, just meninges and CSF in the sac. Cord not involved, usually no neurodeficits.
And the more severe form?
Myomeningocele. That sac contains meninges, CSF, nerve roots, and part of the spinal cord. Sac covering is thin, prone to rupture. Significant neurological deficits are expected. There's also mention of limoningomyelocele involving fatty tissue.
How would you assess a newborn with a neural tube defect? What might you find?
Depends on spinal cord involvement. Obvious visible defect, that sac. If the cord's involved, myelomeningocele, you might see flaccid paralysis of the legs, limp, weak. Altered bladder bowel function is common, maybe hip joint deformities, and potentially hydrocephalus too.
What are the immediate nursing interventions, and what about long-term care and parent teaching?
Immediately. Evaluate the sac size, location, leakage. Assist with neuroassessment. Monitor for increased ICP signs of hydrocephalus. Measure head circumference. Check fontanel fullness. Protect that sac. Sterile, moist saline dressing, non-adherent. Change regularly or when soiled using aseptic technique.
How to position the baby?
Usually prone on the stomach to minimize pressure on the sac. Head turned for feeding. Check for infection signs at the sac. Redness, drainage, irritation. Early infection signs might be subtle. Temp increase, irritability, lethargy, neutral rigidity. Assess for hip joint issues. Prepare for surgery. Give pre-post-op antibiotics.
And long-term teaching?
It's extensive. Positioning, feeding, meticulous skincare, range of motion exercises, bladder program, often clean intermittent catheterization, maybe antispasmodics for the bladder, bowel program, high fiber, fluids, suppositories, and critically educate about the high risk of latex allergy due to frequent exposure.
Latex allergy, right. Okay, let's transition to attention deficit hyperactivity disorder, ADHD. described as a behavior disorder.
Hmm.
Inappropriate inattention, hyperactivity, impulsivity. What challenges often come with ADHD?
Kids with ADHD might face issues with specific areas of intellectual development, maybe minor physical anomalies, sleep problems, higher risk for other behavioral or emotional disorders. Social relationships can be tough due to impulsivity, difficulty reading cues.
Early diagnosis is important.
Yes, it allows for timely interventions to help their emotional and psychological growth. Diagnosis involves info from the child, if old enough, parents, teachers, plus assessment tools.
What specific behaviors might you see in a child with ADHD?
Frequent fidgeting, squirming, easily distracted by things outside or inside their head, trouble following instructions, finishing tasks, poor attention span, jumping between uncompleted activities, talking excessively, interrupting, engaging in risky activities without thinking of consequences.
How is ADHD typically managed? What are the key strategies?
It's usually multimodal. Providing info and support for parent support groups are great. Treatment often combines behavioral therapy, medication, a consistent, structured environment at home and school, and appropriate school placement.
Behavioral therapy focuses on
Preventing undesirable behavior, teaching coping skills, improving self-regulation. Consistency and structure are key. Safety measures, too. Promoting self-esteem is important.
and medication.
Stimulant meds are often prescribed to improve focus, reduce impulsivity. Need to know potential side effects. Appetite suppression, weight loss, nervousness, cytomotics, insomnia, maybe increased blood pressure, heart rate. Reinforce how to give meds properly and the need for regular follow-up.
Okay, now let's delve into autism spectrum disorders, ASDs, complex neurodevelopmental disorders. Core features: altered social interaction, communication impairment, repetitive restricted behavior interests. What about causes?
ASDs are complex, yeah. Causes still being researched. Likely a mix of factors. Genetic predisposition, maybe things happening before, during, or after birth. Possibly environmental exposures. Symptoms usually noticed before age 3.
It's a spectrum, right?
Exactly. Impairments range from mild to severe. The chapter mentions older terms like autism, Asperger's, Rett syndrome, but now it's mostly under the single ASD umbrella. Interestingly, some kids with ASD, savants, show amazing skills in specific areas: art, music, memory, math. Diagnosis involves history, observation, screening tools.
What specific things are assessed across those core domains: social, communication, behavior?
Socially, maybe lack of seeking comfort, abnormal or no social play, trouble with peer relationships, lack of awareness of others' feelings, abnormal or no imitation.
Communication.
Lack of or impaired speech, maybe monotone, maybe echolalia, repeating words, phrases. Abnormal nonverbal communication, lack of gestures, poor eye contact, lack of imaginative play.
Maybe behavior.
Intense preoccupation with objects, very restricted interests, maybe self-injurious behaviors, strong need for routine, get distressed by change, repetitive movements like rocking, head banging, unusual sensory interests too.
What are key nursing interventions for a child with ASD?
Understanding their routines, habits, preferences is fundamental. Maintain consistency reduces anxiety. Use the communication methods the child uses, gestures, pictures, whatever works. Avoid overwhelming demands. Implement safety precautions, especially for self-injury. Help with referrals to special programs. Support the parents. Priority is always a safe, structured, predictable environment.
Great points. Our final category: intellectual disability, defined by below average intellectual function and adaptive school deficits. The chapter mentions Down syndrome specifically.
Right. Intellectual disability means significant limits in both intellectual functioning, learning, reasoning, problem-solving, and adaptive behavior, those everyday practical skills. Must be present before age 18. Down syndrome, or trisomy 21, is a common genetic cause resulting from an extra copy of chromosome 21, leading to moderate to severe intellectual disability typically.
What assessment findings might you see in a child with intellectual disability?
Deficits in cognitive skills, adaptive functioning, delays in fine and gross motor skills, speech delays, maybe decreased spontaneous activity, non-responsiveness, irritability, poor eye contact during feeding, especially in infancy.
What are the main interventions and supports?
It's multidisciplinary, focused on maximizing potential and independence. Medical strategies might address associated physical issues or behaviors. Big focus on community and educational services tailored to their needs. Promote self-care skills, dressing, feeding, hygiene. Help with communication, socialization skills. Facilitate appropriate playtime. Initiate safety precautions as needed. And crucial support for families navigating care decisions, accessing resources and agencies.
Okay. Earlier, we posed that critical thinking question. What do you do if you see signs of increased ICP in a child with a VP shunt? Let's revisit the answer from page 453 now.
Right. The answer highlights being vigilant for those ICP signs we talked about: LOC changes, headache, nausea, vomiting, visual issues, seizures. Post-op, the child is usually kept flat initially. But if signs of increased ICP do appear, the immediate action is to elevate the head of the bed slightly 15 to 30 degrees to help CSF flow via gravity through the shunt, and then immediately notify the RN. The RN assesses and contacts the surgeon. It connects directly back to recognizing ICP signs in hydrocephalus and understanding how the shunt works.
Perfect. And now, to really lock in this information, the chapter includes practice questions, 357 through 365. Let's go through those now with the rationale.
Okay, question 357. Nurse instructs mom of child with seizures about precautions. Which statement needs further teaching? 1. Medical ID bracelet. 2. Companion when swimming. 3. Give anti-seizure meds when child has a seizure. 4. Bike helmet use. Correct answer is 3.
Rationale.
Rationale. Anti-seizure meds are usually taken regularly to prevent seizures, not as a rescue during one. The other options are all appropriate precautions.
Question 358. Child has basilar skull fracture. Which provider prescription should nurse question? 1. Restrict fluids. 2. Indwelling catheter. 3. Keep IV patent. 4. Nasotracheal suction PRN. Correct answer is 4.
Rationale. Nasotracheal suctioning is contraindicated with a basilar skull fracture, risk of catheter entering brain tissue. The other orders are potentially appropriate for managing ICP or monitoring fluid balance.
Question 359. Which lab result verifies bacterial meningitis diagnosis? 1. Clear CSF, high protein, low glucose. 2. Cloudy CSF, low protein, low glucose. 3. Cloudy CSF, high protein, low glucose. 4. Decreased pressure, cloudy CSF, high protein. Correct answer is 3.
Rationale. Classic bacterial meningitis findings in CSF are increased pressure, cloudy appearance, high protein, and low glucose.
Question 360. Nurse teaches parent of child with meningococcal meningitis. Which statement needs further teaching? 1. Give acetaminophen for fever. 2. Watch for hearing loss. 3. Watch for rash. 4. Get other kids pneumococcal vaccine but not baby yet, 3 months old. Correct answer is 4.
Rationale. The pneumococcal conjugate vaccine series starts at 2 months old, so the 3-month-old baby should get it. The other statements show correct understanding.
Question 361. Parents of child with cerebral palsy ask about it. Nurse Simpson responds on understanding CP is which type of condition? 1. Infectious CNS disease. 2. Brain inflammation from virus. 3. Congenital condition causing retardation. 4. Chronic disability with impaired muscle movement posture. Correct answer is 4.
Rationale. Cerebral palsy is fundamentally a chronic, non-progressive disability affecting movement and posture due to brain motor system abnormalities. The other options describe meningitis, encephalitis, or Down syndrome.
Question 362. Reviewing post-op orders for infant with hydrocephalus after VP shunt. Which order does nurse question? 1. Position on inoperative side. 2. HOB elevated 45 degrees. 3. Monitor for infection drainage. 4. Observe for irritability, high cry, lethargy, poor feeding. Correct answer is 2.
Rationale. Immediately post-op VP shunt, the infant is usually kept flat to prevent rapid CSF drainage. HOB might be elevated later, 15-30 degrees, if ICP increases. The other orders are appropriate post-op care.
Question 363. Reviewing record of child with increased ICP showing decerebrate posturing. Nurse expects which characteristic? 1. Flaccid paralysis. 2. Arm adduction at shoulders. 3. Rigid extension pronation of arms, legs. 4. Abnormal flexion of upper extremities, extension adduction of lower. Correct answer is 3.
Rationale. Decerebrate posturing is characterized by rigid extension and pronation, outward rotation, of arms and legs. Option 4 describes decorticate flexion posturing. Option 1 is flaccidity. Option 2 is part of decorticate posturing.
Question 364. Child diagnosed with Reye syndrome. Nursing care plan should include which intervention? 1. Assess hearing loss. 2. Monitor urine output. 3. Change body position Q2H. 4. Provide quiet atmosphere, dim lights. Correct answer is 4.
Rationale. Reye syndrome involves cerebral edema. Key nursing care focuses on managing ICP. Decreasing environmental stimuli, quiet, dim room, helps reduce stress on the brain. While monitoring urine output and position changes are generally important, they aren't the priority intervention specifically for the encephalopathy of Reye's. Hearing loss isn't a primary focus. HOB should be elevated.
Question 365. Nurse gives home care instructions for child with ADHD behavioral therapy. Which parent statement needs further teaching? 1. Side effects of meds can cause overeating. 2. Consistent meds and regular follow-up are part of the plan. 3. Need consistent home environment, child easily distracted. 4. Need to learn behavioral mod techniques for impulsivity. 5. Correct answer is 1.
Rationale. Stimulant medications commonly used for ADHD often cause appetite suppression and potential weight loss, not overeating. The other statements reflect correct understanding of ADHD management components.
Well, that wraps up our very comprehensive deep dive into neurological and cognitive disorders in children, all drawing from this really detailed chapter.
You covered a lot of ground.
We really did. From the basics, the assessments, the crucial interventions for so many conditions,
Yeah.
always keeping those key concepts, intracranial regulation and safety, right up front.
We went through cerebral palsy, head injuries, ICP signs, hydrocephalus management, meningitis types and care, submersion risks, Reye syndrome features, seizure classification, and emergency care.
Caudal tube defects, ADHD management, the ASD spectrum, and intellectual disabilities.
Yep, covered them all.
Our goal was really to give you a solid yet understandable foundation on these important topics. We hope this deep dive hit that mark for you, giving you a stronger base for future learning or for handling situations you might encounter.
And this exploration really drives home how critical early identification is for these disorders and the power of that multidisciplinary team approach in really improving outcomes for these kids.
Absolutely.
It makes you think, too, about that deep connection between neurological and cognitive development and a child's overall health and well-being.
It really does. So with that, we can definitely say we have thoroughly covered all of Chapter 35, Neurological and Cognitive Disorders, from the Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition.
Complete coverage.
Thanks so much for joining us on this deep dive.